All right. Thank you, Mahin. Mahin has been doing great job whole day. Can please everybody come in? Noah, can you go out and shout a little bit? Okay. So basically, AI is like open word. It could be anywhere from grocery store to Amazon to healthcare to logistics, everywhere. So in this session, we'll try to sort of compose it in a way like what are we doing with where we can use AI in education, in patient flow management or your work, daily work, and also anything new in diagnostics using AI. So we'll divide it into three parts. And I think, Danish, are you here somewhere? Yes. So our first speaker is Danish. Danish is my friend, so I can call him Danish. Danish is actually not a dermatologist. He's a neurologist, but a professor here at the university who's involved a lot into teaching. And he has learned and taught many people using AI and how can you improve teaching using AI. So Danish, please come in and you can reintroduce yourself if I didn't do it well.
Thank you, Dr. Rao. So I will just spend a few minutes, hopefully less than 10 minutes, in giving you some context on at least one aspect of use of AI in medical education. AI is such a broad topic, we have to focus on a particular area when we are reviewing it in short time. But let me start with this context. When we think of AI working with us humans, we should think of these levels of independence or automation. So level one, when human is working only and AI may be observing or no AI involved or learning. Level two is where it starts working in shadow mode and starts making decisions which are not being used in runtime, but you can go back and audit. Level three is where AI assistants actually start and human is responsible, but AI is providing some useful information, maybe analysis of data or crunching the data. Level four is where there's partial automation. Some simple decisions are being done by AI, which are easy to take, low risk decisions, but most of the high risk decisions are still being done by a human. And level five is the full autonomy where AI does all the decision and can be audited later on, but at the runtime, there is no decision making involved by the human. So we are definitely in level three and starting to go into level four in many aspects, including education and medical education. I thought I'll keep the talk very practical on tools that are already available in the market. So if you want to go or you want to build, you'll see what is being built and launched in medical education. And for this specific talk, I focus just on tools being used in assessments. Part of the learning, I think it's becoming majority of the learning is assessments. What have you learned? So we have these formative assessments, which are replacing lectures. I will quickly give you some tools and ideas about how AI tools are being used for personalizing the learning, using virtual patients in clinical simulations, the assessments and feedback, clinical reasoning, decision-making, and research and data analysis skill. So let's start with personalized learning. The idea of personalized learning have been there for a long time, but the problem is that how do you adopt it to a student at really custom level, not just a group so continuous assessment and feedback. One of the tools that can do this on a runtime will be using AI to ask questions and then build the learning around that. So interact with the students as you are building the learning for them. So one such tool is called Newton Alta. This was a project by Willy. It's still available, not commercially, still more like a pilot or beta testing, where they are creating adaptive courses. So each student's course will look different based on how they're progressing. So it's almost like those stories or role-playing games where the game adapts to the player and becomes easier or harder depending on how good they are performing. So it's the same idea that each person's course will progress at a different speed to a different level of achievement based on their performance. Another similar tool in medicine is osmosis. It's not that customizable. It's a relatively structured program, but the courses are being created, which are then selected based on students' performance. So there are pre-created courses, not created at runtime, but the selection of the course or the lecture is dependent on how student is performing. And there is some human involvement. So it's more of a level 3 performance compared to the Newton Alta is more of a level 4 automation, where it is partially automated. This is more of a human dependent automation. Another example is IBM Watson, which is a scalable dialogue-based tutoring system. So it's almost like those dialogues from Socratic methods, where you ask question, you give answer, or student give answer, and then you ask questions, student give next answer. So you can almost have a dialogue-based learning instead of a lecture-based learning. So if I need to teach someone something in neurology, let's say stroke or Parkinson tremor, on bedside, we often do this kind of a dialogue, a back and forth debate. Okay, how many types of tremors there are, or what happened to this tremor, what happened to that tremor. And that is kind of being lost because it's very intense, human dependent. You can't scale it, you can't use it in every scenario setting, but AI will allow you to develop those kind of teaching tutors, individual tutors. Jumping to virtual patients clinical simulation, we have been doing this for a long time, but one thing was missing, that these simulations required very extensive pre-written scripts. So it was very scripted and everything was pre-written. So it would take months to write a script for a case. You have to think of all situation. You have to think of all level of complexities. It was like 40-page long. Then you have to take these people, facilitators, you have to train them over weeks on what the script look like, what to do in situation A, what to do in situation B. But all of that can go away. The AI can generate these scripts in runtime, so you can create a virtual simulation, and there is no pre-written script. You can just predefine some of the criterias, outline, and then the script will get written as it is. So this is one example. It's called Body Interact. It's virtual patients which are using these LLM scripts behind the scene and not pre-written scripts. Another example is this iHuman Patients by Kaplan. And again, the idea is to not have completely structured scripts and just have, so each time you run through the scenario will be different based on what responses you're giving. Another topic would be assessments and feedback. One of the challenges have been that when you take someone's, for example, a pre-written H&P, you had students go talk to a patient, write an H&P. It takes a lot of time to sit down with them and tell them what questions they could have asked differently, how to grade those H&Ps, what was their performance with the patient, and grading all of that and giving formative feedback. We explored this idea in a research that can LLMs generate feedback on these H&Ps and can they grade them? So we have these H&Ps that are being graded by faculty preceptors in a third-year clinical clerkship. And so we already have that data. We had the LLM grade them and give feedback, and we found there was almost 92% concordance between the grade. So LLM is giving the same amount of grade as they would get from a human preceptor, but then they were able to give a far more detailed feedback on what was missing in each section of that H&P. So we're already showing that in data gathering, clinical reasoning by the students, diagnosis creation, LLMs can start giving them very, very detailed feedback. And similarly, there is this ambient AI. So right now, ambient AI is being thought of as a documentation tool, that it listens to you and creates a patient note. But it's a very excellent teaching tool, because as it listens to your student interact with the patient, it can then generate a detailed feedback for the student, that where were you missing? We looked at our tools to see if they can detect empathy. Can they detect, okay, the language, the tonality of the patient? And these can, even just on wording. But imagine adding audio on top of it. Now they can create a detailed report for the student after listening to that interaction later on, that, okay, you can improve on your language this way, you can improve empathy this way, these are the wording you can use, you could have said this sentence this way. All of that was missing before. We did some of that, there are in clinical practice scenarios where we go and observe. We just sit down and have the student do it. But if you are being there, automatically just completely disrupt the interaction. So imagine having it been done by an AI by just listening in. Another thing was questions generated. We are doing these multiple choice questions over and over again. They are pre-written. It takes so much time to write them. Then there is a selection process. In 2 years, they become useless. You have to generate the question bank again. The LLMs can generate these questions very, very quickly and very, very well. Right now, I think they are at level 3, getting on to level 4, but I can see a future where the questions are being generated in runtime by the LLM and not pre-written at all. And they will be as good or better than the questions being written by human. This is an example, a tool, a project that we started using ChatGPT and then doing some fine tuning and training afterwards. You can give it a file like your lecture, and it will take that lecture, go through it, and create 10 questions or 5 questions for it. And then you can keep generating questions. You can just hit next. It will change some of the scenarios in detail, and it will create a new questions. And you can see some of the stems that you have. You can walk it through some of the settings that you want for the questions. Clinical reasoning and decision making is probably the hardest one. There's not a lot of publicly available tool. There was a project started at Harvard a long time ago called D-Explain. This was pre-LLM one. I think it's kind of died off, but I think it can be survived or revived now, which basically discusses the differential diagnosis, how you're thinking. If someone coming in with fever or a rash or something, what would you ask first? Based on your feedback, we'll say, okay, now what will differentially generate? So we'll walk you through that exercise of generating differential. LLM can now do this very beautifully, but I don't see any publicly available tool out there doing this. So, an area of opening. And then similarly, research and data analysis, there is writing tools already available that will co-write the script for you. Jenny.ai is a good one, is early one, and a more recent one is Paper AI or Paper.ai, which will write the paper for you. You tell him your general kind of an idea of what your research was done. He will create an initial draft for you, then you can edit it. And similarly, evidence discussion. There are many tools out there that has absorbed the evidence, and you can just ask it a question. Open Evidence is a publicly available, very reputable tool. There are many other tools like that. Even ChatGPT probably can do it, but it hallucinates. The tools like Open Evidence, they have been filtered so that they have actual research data that they will quote. And you say, okay, I'm giving you this answer based on this evidence, based on that trial over there, and seems to be far more reliable than just asking ChatGPT about evidence for something. This was a summary from me. Thank you so much. Appreciate your time, Dr.
Thank you. Thank you. Well, thank you. That was excellent. So professors don't have to write questions anymore. It takes a lot of time. Next is actually everybody in dermatology, at least in North America, knows Art because he has done some wonderful job initially with images and then added a lot of stories to it and then produce this excellent learning and management tool. I know Art for many years, and he really has worked very hard, very patiently with what he's trying to do. And I think he's at a point now that he can teach all of us what should we do.
Thank you, Babar. Really a pleasure to have an opportunity to share some ideas. Without mentioning some names, there are people in this country that believe that we're going to colonize space or believe we're going to colonize Mars. And there are some people that believe that we won't need doctors in 10 years, that AI is going to take over. And I don't subscribe to any of that. Right, so this really is a presentation about thinking about how we can use AI to make us smarter, not stupid. So there's a whole field about de-skilling, how AI will take away a pilot or a driver's ability to really drive the car because we're going to over-rely on technology. So my take on this is that we're going to need more healthcare professionals, and we're going to need tools to help healthcare professionals do a better job. So let's think about improving dermatologic diagnosis and care delivery in medicine broadly, and not just think about how these tools are going to help us as dermatologists. So this is a patient in a study we did at University of Rochester. She told us that she had 3 hospital admissions in 6 months for this. Most dermatologists know that that's the wrong diagnosis. They thought it was cellulitis. It was bilateral erythema, but the woman had panniculitis. Now, 30 years ago when I was a resident, this was a problem. 30 years later, it's still a problem. So we can develop wonderful therapies for HIV, make it a chronic disorder, cure hepatitis, incredible progress in oncology, but we can't solve clinical reasoning. And that voltage drop in care is costing this country a phenomenal amount of money. And it's also harming people. So it's an ER physician that's making these decisions, or an internist. And frankly, their job is a lot more difficult than our job. They have over 500 chief complaints that come into that emergency department. And it's no wonder that they prematurely close on the red leg as cellulitis. And so these diagnosis and treatment errors lead to a lack of beds because you put that patient with cellulitis in the hospital when you needed that bed for someone else. So diagnostic error is one of the undersung problems in healthcare. And it's not just about missing rare diseases, it's missing common diseases. So there are inappropriate referrals and admissions, delayed effective therapy, patient dissatisfaction is incredible, lack of trust, and increased healthcare costs. So if you look at these four cases, a skilled dermatologist or AI is going to want to ask questions. You're not going to be able to firmly say what the diagnosis is. You probably could say, well, they look like exanthematous eruptions, morbilliform eruptions, but you'd want to know, did the patient travel? Did they start a med? What's going on? So you have to know the questions to ask. But if you don't know the questions, you don't know what to ask. So really the question for this group thinking about AI in medicine is, how do we use computer-based information and AI to guide us in asking the right questions so we can truly personalize the patient interaction? So I'm not talking about binary problems. You look at the image, it's a basal cell, or you look at the image and it's molluscum, and you know immediately. I'm talking about more complex problems. So in designing information systems, I urge everybody to think that it's not just a technology problem. Medicine, because of grayness and ambiguity, you need to think about the culture of medicine. You need to think about how clinicians solve problems. And if anybody's read the book, Thinking Fast and Slow by Daniel Kahneman, it's kind of a Bible for people thinking about clinical reasoning and how we make fast decisions or slow decisions. And important is really an understanding of cognitive biases. I'm only going to talk about one or two. And the bias I want to talk about is summarized by this idea. So I don't know how many dog lovers are in the room, but I'm a dog lover. So imagine you go to a breeder and there's 7 puppies, and the breeder hands you a puppy and you fall in love with the first puppy. And you say, that's it, I'm done. So there's really a litter, and you could actually look at all the puppies and choose the one that really fits you, but you just grab the first one. And that's premature closure. You latch onto that first diagnosis and you don't move off of it. You don't consider the other possibilities. So AI can actually increase premature closure. So imagine you have a system where you say you rank probabilistically that the top diagnosis is 95%, the next one's 58%, and the user is a primary care doc that just loves this tool and just says, oh, it must be this. So people could over-rely on these tools. I mean, they really could jump to conclusions based on these tools when the sensitivity and specificity of these tools aren't really there. So in thinking about this field of clinical decision support that predates large language models, predates machine learning, is how do we use computers to improve decisions? So the equation is brain plus computer is more powerful than brain alone. Now, there are some situations where it's a binary decision, like there's now an FDA-approved software as a medical device for diabetic retinopathy. And you can take a picture, and the picture alone will say, yay or nay, diabetic retinopathy. And certainly in our field, we'll see this for some binary decisions, or probably around nevi or solitary lesions. But once you get into rashes, it becomes a lot more complex, and you're more into this model of augmented intelligence. And so I'm a believer in this idea that we can develop tools that make us smarter. And we want to encourage the tools to upskill us. And we want to build feedback loops into the tools so that we learn from our mistakes and we learn from the decisions that we're making. And so at Visual DX, our journey with machine learning was to purposely build the step in where you take the photo of the rash or the lesion and you see where the arrow is. You don't go right to a diagnosis, you go to a morphology. So this is actually a case from an emergency physician, University of Maryland. And the patient came in with a bloody, quickly growing lesion on the finger. And the ER resident didn't know what it was. And the attending said, oh, we have a new app, let's try it. So he used it, and the punchline at the end, it was a pyogenic granuloma. But what he said to me was, he Art, friable papule, that's not ER speak, that's derm speak. But we took him through a process of using the machine learning to train him in the language of dermatology and expose him to morphology, location, answer some questions to get to higher fidelity in what you're doing. So we're combining the machine learning with questions. And where we're heading in the future is really to start personalize those questions based on medical history and other factors. And now we're starting to work with large language models where we're trying to hybridize large language models with machine learning. And an example of that would be currently in Visual DX, you can't just type in a natural language string, but this is an example of 27-year-old Sudanese male, widespread white spots, where the large language model is moving white spots into hypopigmented macules that are in our database so that we can get to a differential diagnosis based on a natural language string. And we also work with patients and consumers with our app ASA. I encourage anyone to download it, it's free. And the idea is to improve education of the skin in the home with consumers. And we have a lot of experience with this now, having done this for about 5 years, and really interesting comments from people checking up on their dermatologists after the visit because you gave them so little time in the exam room, they don't trust you anymore. You were right, but being right didn't matter. The fact that you were moving so fast, they didn't trust you. And we see all these comments from these people using ASA saying, yeah, oh, ASA agreed with my dermatologist. So it really doesn't matter that sheepskin on the walls from your university. They don't really care about that anymore. They really, they have the internet, they have Google. And so let me close by just reflecting on our uncertain times that we're living through and doing good in the world. I just came from the GlowDerm meeting. GlowDerm is an incredible organization. They're doing good in the world. CeraVe, which is part of L'Oreal, GlowDerm, and Visual DX are partnering to bring Visual DX to users around the world. And so there's Esther Freeman of GlowDerm at the Regional Training Center in Moshi last year, training trainees in Visual DX, and it's all supported by this project called Care for All by CeraVe. It's really a wonderful example of industry doing good in the world. And I said I love dogs. Anyone in the room heard about Dog Mountain? Fantastic. We have a hand that went up. So Dog Mountain is a nonprofit in northern Vermont. Artist Stephen Hunick passed away and a nonprofit was formed. That's the dog chapel that he built. And if you can't see it, it says, welcome all creeds, all breeds, no dogmas allowed. And so the chapel is incredible. It has just memories of dogs in the chapel that people have written, stained glass window of dogs, pews of dogs. And if you love dogs, Google Dog Mountain, get involved with Dog Mountain. It'll make you feel good. Thank you.